You said I should just go straight.
Santos will speak.
Okay. Yeah.
Chipner want to say one word.
Oh, they want to. Yeah. So
We'll introduce Dr. Chim so that Dr. Chim will say one word.
Okay.
Hello. Yeah, let's go to the stage. We welcome you all to this screening. We thank God for another day. Before we go ahead, we have our CHIPNET president, who is here with us all the way from Southampton. Dr. Chim is a gynecologist consultant. She worked with Southampton Hospital, and she has been a consultant for a decade. She is a speaker. She is one of the women in NICE guidelines. She is a member of Royal RCN, and she is a speaker for a lot of conferences. And she is a woman with a husband, one husband, and one child. She loves the word of God. She is a deaconess in the Church of Pentecost. She is part of the National Women's Executive, and we are honored to have our president, Dr. Chim Kalombi.
Thank you very much. I just wanted maybe to correct something. I'm not a member of the RCM. RCM is the Royal College of Midwifery, so I just wanted to make that right. But I'm a member of the Royal College of Obstetricians and Gynecologists. But I just want to thank you all for coming here. More especially, I think I want to acknowledge our speakers that have come to support this event. We will be introducing them as they come to give their talks today. But it's been an honor to have you all, and I just wanted to acknowledge all of you. We just also want to acknowledge the Church of Pentecost to give us this platform to host this event as a subsidiary of the Church of Pentecost. So I'm going to talk briefly 5 minutes about the Christian Healthcare Professionals Network. Christian Healthcare Professionals Network is an independent subsidiary network. It's a network of all healthcare professions who are Christians that come together with just one goal. Our goal is to connect with each other, to save our communities, and above all, to make an impact in our communities. Throughout the talks today, you hear statistics that are alarming, especially about the healthy outcomes among Black, Asian, ethnic minority communities. So we've come together to use the skills that God has given us, what we know. This is like the road in our hands that we can use. Even if we save a life, even if we change somebody's mind perception, even if we get somebody to seek help early or identify a problem that can be prevented, then it's worth the cost to do it. But we cannot do this job alone. We need you guys who are healthcare professionals in the area, in Telford district, within other churches. Invite your colleagues at your places of work to join us so that we can make an impact in the communities that we live. We don't want to be numbers. Every time you hear Black, African, Afro-Caribbean, this is the number, poor kidney outcome, 5 times more women die in childbirth. These numbers are alarming. We want to wake up to a society one day whereby we won't have to be the numbers that we are counted for, but we will change and impact the outcomes of our society, of our communities, of our women, of our men, of our children. So that's why we're here today as an organization hosting this event in the communities to get the community to come so that we can change the outcomes of the communities. So thank you very much for coming. For more information, find us on our website, www.chipnet.org.uk. We are on the social media handles. If you have any problem at all, apart from the stations that we have today, in the morning it will be the talks, imparting knowledge to you guys. In the afternoon, we have the screening stations. So these stations, we've got the kidney screening station, which will direct you to go. We have also an advice stations that we've set up. We have the diabetes station, we have the prostate station, we have breast awareness station, we have menopause. Yes, menopause. Let's talk about it today. Are there women in the house today? Okay, so we have the menopause station. We have polycystic ovary syndrome for our younger ones. Some of us, maybe we've been having issues conceiving. We've been having issues with our periods. So please, all the experts are in the room. We are here to provide to you one-to-one consultation. And if you need private discussions, come and find us. In addition to that, we know that mental well-being is an issue and it's a problem. And among faith communities, we don't want to talk about mental health. Sometimes that can be looked at as a taboo. We have psychologists, clinical psychologists in the room today. We have our pastors that will also be offering counseling one-to-one. So please use us today. We are at your service. We are here for you guys. If you need one-to-one, if you need advice, if you need signposting, if you need resources, that's the reason why we have this event. So use it to your benefit. So I just want to thank everybody, and we'll now start introducing our speakers so that they can give us the messages for the day. But thank you so much for coming, and thank you so much, Pastor Emmanuel and the wife, for hosting us today. Above all, I want to just say something. My chair, Mr. Joshua Malcolm, I don't know where you are. He's the man behind all these things today. It takes a lot to organize something like this, and he and his team, they've been so wonderful. So welcome and enjoy the day. Thank you.
Thank you, Dr. Chin, for that amazing opening statement. Shall we clap for our Dr. Chin? So like we said, we're going to get started. So our first speaker is Sandro Garza. So I'll just introduce him again in case we've forgotten. So again, PhD researcher in polycystic ovary syndrome and focusing on lifestyle interventions to improve the quality of life for women with PCOS. So he's going to come up and just speak about this topic, enlighten us before we go and do the screening. So let's give a hand to our Dr. Garza.
Wow, that is quite the introduction, and quite the introductions, because I've never been to a place that was so warm, and there's a drum kit. It's going to be pretty exciting as well. Thank you so much for this. So so just a quick one. So my name's Sandro Grassa. I'm one of the PGR students at the University of Wolverhampton, and I'm here to talk about polycystic ovary syndrome. So you'll hear me talk about PCOS, which is a term that is used for that all the time. I didn't get my clicker, sorry. Oh, is the pen? Oh, this is very sophisticated. Hang on. So if I go this way, no, or that way. Let's try the other one. Ah, it works. Cool. Okay. So so as I said, University of Wolverhampton. Thought he was going to give me two mics, 2 introductions and 2 mics, and that's where I got to meet Joshua. And if you want to, I'm going the wrong way, sorry. If you want to see us, we're probably going to be out that window there. If Joshua is here looking at the screen, you'll recognize where we got to meet at university.
And I'm doing my PhD, and just recently I got to publish the first paper out of that PhD, and that is to do with PCOS and the use of anything to do with the internet. So it's called Internet of Things, but that's to do with social media. It could be websites, mobile apps, anything that not just patients, but also clinicians and researchers are using to get information about PCOS. Along those lines and the work that I do, I'm part of the Androgen Excess PCOS Society. That's me there. That was last year, and I'm one of the early career part of the special interest group, and I'm also the social media editor. So you'll hear me talk about social media all the time, and I'm glad it was mentioned already today, because it is part of the important work of getting awareness, not just for the public, but also for other clinicians as well. So polycystic ovary syndrome, why are we talking about it? Just briefly, it's a very prevalent condition. We're talking about the latest update being between 11 and 13% worldwide. The economic burden is huge. So for example, for the UK alone, you can see the difference in 10 years going from 200 and something million to almost 950 million in the space of 10 years. And come on, next one, yeah. Part of that reason of the economic impact is how it affects so many different aspects of a person. So it has metabolic implications, so that's to do with your body and your metabolism. It has reproductive consequences as well for the woman, and also the very, very importantly, and I'm so happy that was mentioned already, the psychological impact that will have for the person and the family as well. In terms of the guidelines, the main thing that is recommended is a healthy lifestyle. I know it sounds a little bit vague, and I'll talk a little bit more about it just to give you an idea, but it is something that, because there is no cure, it is something that you're dealing with managing symptoms rather than curing it and getting rid of it forever. So we spoke about the guidelines. I'm one of the researchers that was part of the international team that worked on the guidelines. So I worked on those two papers, one on anti-obesity medication and the other one for inositols. That was a huge international team, so it's a big, big effort, and I'm so glad that everyone from all over the world is involved in this. And apart from publishing and having that, the closeness and working with other people, what really fascinates me about PCOS is the fact that it actually affects people throughout the whole lifespan. So you have from adolescence all the way to postmenopausal. And the things that we knew already from it was during trying to get pregnant and also during pregnancy. So it is a condition that will affect throughout the whole lifespan. So talking about the guidelines, and I just wanted to make sure that everyone was aware of the website and the app. There's actually an app for that as well, and it's called Ask PCOS. And some of the things that I would like you to at least have a rough idea is the principle behind having all this information online is to get more people informed. So here's one of the infographics, the leaflets that we have on that website for Ask PCOS. Even for you to find out a few questions on should you actually talk to your doctor. So you answer these questions. God, I wish I could see that from all the way here. So that one is about menstrual cycle. So menstrual cycle, are they irregular? Are they absent? Are they just coming up, you don't know when they're happening or not happening at all? God almighty, I really need to check my eyes after this, huh? Excess hair, and I'm going to talk, obviously, it's going to be the excess hair and the acne. This is actually something that is really important, especially in younger life, obviously, with acne and excess body hair. So these things are normally seen either in the face area or the back. One of the ones that I remember seeing in clinic a lot was just below the belly button area, if you see any hair there. And then talk to your family as well, and finding out if anyone in your family has had any history of these complications. Because as we know now, and this is quite recent, it is actually something that is genetic between the family. So just check, and it will be good to talk to other people as well. So this leaflet goes through these 3 simple questions. If you answered yes to any of these and have any of these symptoms. And as you come down, the leaflet will then show you, if it works, come on, it will show you. Here we go. So the symptoms that you are looking for, as I said, irregular menstrual cycles or absent menstrual cycles, providing that you're not on the contraceptive pill. Difficulties getting pregnant. Again, the excess body hair. You have the excess body hair, again, it will be quite noticeable where it is, and also things like the darkening of the skin that can happen to people as well, and you'd see it around the neck area too. Acne, I've mentioned already, so it'd be very, very prominent, especially for the teenagers. They will notice it straight away. And here it is, the importance of mental health. So if there's any of these issues are getting you down, please do get checked. And weight is a big, big issue. So we know that a few years ago, there was a lot of emphasis put on weight and excess weight for PCOS. We know now that it affects everyone across the spectrum, so it's not just related to weight. But the issue is that those that do have the condition find it really, really easy to put on weight, but then really, really difficult to lose weight. So that has then the mental implication of it just, you can imagine that anything that you do, anything that you eat, you put on weight, but then it's really difficult to actually lose that body weight. So things to know that I'm just highlighting there from the leaflet, and again, this is all available on the website and the app as well, so for you to scroll through and to learn about. It's a long life condition, so it's not something that, as I said, that you're going to fix with something, so you're going to have to need management throughout your life as well. There's a lot that we need to know, even for researchers and for clinicians that are here in the room will agree that we're only at the tip of the iceberg, and there's a lot of implications with the condition. The reason why the guidelines are important now is just to give it more universal aspect of making it easier and quicker to get to a diagnosis. So where before you would need scans that would be more expensive and you would be waiting for them, there are more blood tests and levels that we're more in agreement in terms of giving a diagnosis to a person so that they can start their treatment. In terms of conception, it's really, really important to not just to think that you're going to go to a clinic and it's going to get fixed. It might, but IVF is not the end of the solution for this condition, because even then during pregnancy, there will be implications for the pregnant woman and the baby as well. So that needs to be looked at with a health professional. As I said before, in terms of looking at mental health issues, it is complicated. Like if you think about, again, with the adolescents and how they will be, there is the possibility of even being bullied by others in school because of their appearance. And yeah, the emphasis is on lifestyle. So lifestyle will help. Again, it's not going to fix the problem, but it will make a big, big contribution for you to have a more healthier lifestyle throughout managing the condition. There are solutions that have been added to the guidelines, like laser for hair, and again, it's not the full solution, but it does help for the woman. During pregnancy, we know that there are issues. So for example, just to give you an idea, it's not exclusive even to women. So for the babies from that pregnancy, even if it's a baby boy, there are consequences for the health of that child throughout their life. So it is something that you do really need to look at. And yes, there are treatments and there are medications that you can take to help you with getting pregnant, but you still need to be monitored during pregnancy as well. And yeah, so please do talk to, there are solutions, but you need to talk, you need to speak up and talk to your clinicians, because you need to be guided and need help throughout this. Talking just quickly about fertility and pregnancy, as I said, there are options to manage this. So for example, if your cycle is being irregular or if it was completely absent, you talk to your GP or your consultant and you will get help with that, and even with the IVF clinic as well. But again, you need to talk to people and you need to communicate your issues, because it is something that it's not a quick fix. You need time to work through this. More than thinking about the word exercise, it's actually being active that matters. So don't think that just because you hear lifestyle or that you think about, you know, it's a weight-related condition, so you need to lose weight. It's actually not so much about the exercise, it's about remaining active. So one of the quick things that I always say about this is, I was involved in research where we found that it's going to be very generic and just to give you a number, but a 5% weight reduction, 5%, which is little, makes a huge difference. So it's not about going to the gym, it's not about losing lots of weight, it's just about being active, because that makes a big, big difference to the whole metabolism of the person. And that, as I said, is just encouraging as well. There's no way I can read that, I'm so sorry. This is really, God. Yeah, more helpful information. The information is out there, and the reason why I'm just highlighting this from the leaflets is because although the whole international team came up with these, this is not something that it's exclusive to healthcare professionals. This is actually information that has been tailored for the public and for you to know. And even this particular website has information that you can fill in and stuff that you can download when you're coming up to bring to your GP. So it's a reason why I really like this website is you can actually download information from the site, fill in predefined questions, and actually bring them to your GP when you're talking to them for the first time. Healthy lifestyle is very important, so please do look at what little changes can you do in your health to make an impact. And as I said, even when you think about weight, 5% is a big, big difference. And yes, as there are medications available for helping with this, just always bear in mind, and I'm always very upfront with people to say that you're not going to find a silver bullet. It's not going to be something that will fix everything forever. There are options out there, but you do need to consider, and you need to be taking into account your own medical history and your own background, and talk to the people that are helping you medically. I left this one for last because it's really, really important, and if anything from what I was saying here, and if anything that you go and check on this website, please do check this one about mental health and well-being, because it's really, really important. And two words that are mentioned there are awareness and monitoring. And you can only do this with support. Support from others, so support from your own community, and support from others that have been dealing with the condition for longer and can give you advice as well, but also then the monitoring from health professionals. So you have, again, the principle of this website and this app helping you with giving you some predefined questions for you to answer and to see at what level you are and where you should go and ask for help. So there's a few examples there that will ask you about your mental health. And then it will say that ideas and ways to reduce the risk and the severity. Again, remember, it's all about managing these symptoms. So to finish, there are groups here in the UK, like the one that I really like, and we work closely with them, patient groups, Verity, they're online as well. Their forum is quite active, and they get people that have PCOS and have been dealing with it for longer to give you advice and to help you through the condition. So, and they do have regional groups as well, so that would be important for you to look at. And as I said, there is an app, there is a website. All this information that I was sharing with you here today is from that information, from the guidelines. So please, as much as I love social media and internet, I do know that a lot of people like to follow influencers and learning from other people on the internet. Please do check the guidelines and get support from medical people as well, because it is something that you will need to manage, and speak to people in your community as well and others that are dealing with PCOS. Thank you very much.
Come on, guys, you can do better than that. So that was a quick, brief understanding on PCOS. So if you do have questions or you have concerns, please don't worry. After all of our speakers have spoken, there'll be about 2 hours where we can go and ask questions and gain more information. So our next speaker will be talking to us about hidden chronic kidney disease, and the person who will be speaking on this topic to us will be Rosaline Ajikum. Rosaline Ajikum is a person of faith, a mother of 2, and a registered nurse. She is working for King's Kidney Care as a community kidney nurse researcher, lead nurse for clinical practice and education, and senior lecturer practitioner at King's College London. So someone very knowledgeable about kidney health. So we're just going to call our Rosaline Ajikum to come and speak to us.
Thank you. Yeah. How does the pen work?
This is the pen, so I
Yeah,
think this is
forward.
that's forward, and I think that's backwards. Yes.
Good morning. Are we still sleeping? I am feeling a little bit sleepy, but I hope that I would be able to keep you awake. So my name is Roslyn. Fingers crossed it will work. I'm going to try again. How was it? Not working. Not sure I've broken something. Check for me. Oh, okay. All right. Thank you. So whilst it is uploading, I would like to say something briefly about why I am passionate about kidney health. So it's not simply because I work at King's Kidney Care, but kidney health is really passionate to me because I have family members who have had kidney failure, and majority of them are not standing here with me. And my passion is that everybody would get to know their kidney health status so that together we can protect ourselves, protect our loved ones, and protect our community. And that is my whole passion. Now, this is a teamwork, so this is not just about me. And what would I like to talk through for the next 15 minutes is to look at the kidneys. What exactly do they do, and why should we even talk about kidney health? And then so much inequality. So what do the kidneys do? What is the link between the kidneys and my heart? Why I should be looking after my heart health as I look after my kidney health. And I know there is a speaker here who will talk about heart health. And then finally, what can I do to protect my kidney health? Just briefly. Okay. So when we talk about kidneys, what exactly are they? They are two bean-shaped organs sitting just before my backbone. One of them on either side. And I'm going to be controversial here. And anytime I say that, people ask me questions. We all have two. But we can all live with one. We all have two kidneys, we can all live with one. And then people ask me, but if we can live with one, why were we given two? The second one is what I call gift of life. So the second kidney is gift of life. We all have two, we can live with one. The second one is meant to be a gift for somebody. What is actually inside the kidneys are very, very tiny blood vessels. I call them filters, very, very tiny. They are so tiny, they are like the strand of a silky hair, not my Afro-kinky hair, a silky hair. You can imagine, very, very tiny. And because of how tiny they are extremely sensitive to pressure. So whether it is pressure from high blood pressure, or pressure from me eating too much salt, or pressure from not managing my diabetes very well, that is what these organs are very sensitive for. Now, if we look at it right here, you can see, so these are those tiny, tiny blood vessels in there. And can you believe it? These organs, I'm going to make a, so they are like about the size of my fist. That is how they are. And if you look at that, 1,200 mils of blood enters both kidneys, these small organs. Okay, 1,200 mils. And in a day, they are filtering 1,700 liters. Those of us here who drive, we know how much that will be. Several gallons of fuel. These very small organs, so they are so powerful, and although they are very small, and that is what keeps us going. None of us sitting here would be able to walk, talk, move without the kidneys. And that is an absolute truth. Because if you look at it, what exactly does the kidney do? For me to get strong bones and teeth, my kidneys. For me to be able to move water around my body, my kidneys and my heart work together. This morning, some of us have, or most of us have had breakfast. Our stomach is busy digesting whatever we've eaten. But for the body to take what it needs and get rid of the ones we don't need so that it comes in our urine, Mr. Kidneys. So that is the beauty of what a kidney does. If we take in any medicine, the kidney is responsible to take what the body needs. It has to get rid of what the body doesn't need. So it does so many amazing things in our body. Blood. We all need blood. We cannot survive without blood. But that is the work of the kidneys, to make sure that it produces a special hormone that will make the blood cells that we need for us to breathe and to live. The kidneys. Okay? And I like using the bin as an example. Dump the junk. Okay? And that is what the kidney does. So whatever we've eaten today, like I said, the kidney would help the body to take what it needs, and what it doesn't need, it will come as part of our urine. Okay? So when we talk about kidney health issues, what are they? Now, please do bear with me. I'm not talking about the ones that happen suddenly. I'm talking about kidney health or poor kidney health that takes a longer time. It takes a longer time. Okay? So gradual loss of ability for my kidney to do all the nice things that I've just spoken about. Filter the blood, make sure my heart is working well, longer time, okay? And these laws cannot be reversed. That is why I said this is different from kidney health issues that happen suddenly. This gradual loss, once we've lost it, it cannot be reversed. Well, somebody told me, Rosemary, that is not true. Because God can reverse that. And I said, okay, I leave that to Papa God for him to reverse that. But we need to be aware that long-term kidney health is not reversible. Okay. What are the main risk factors? And you can see there, diabetes. However, there are also risk factors to the diabetes itself. So sometimes as women, when we are pregnant, we may get diabetes during the pregnancy. And after we deliver, there are many of us who recover. But other people, after years of recovery, end up developing diabetes again. Okay. Also, pre-diabetes. When we say pre-diabetes, all it means is that my body is getting to the stage where the organ that helps me to regulate blood sugar in the body is no longer functioning very well. So if we think about, and I like using an analogy, so think about my body having to move blood sugar from my blood to every area, but the organ that helps me do that, which is the pancreas, is not able to do it properly. That then increases my risk of developing diabetes. Okay, so pre-diabetes will be about that. And we know we have the diabetes team here as well, who would help us. Being overweight. Okay, and then also, if there is any family history of diabetes, it increases my own risk of having diabetes. Then being physically inactive. The second risk factor is high blood pressure, or hypertension, as we call it. And if we look at that, we can also see that the risk factors for developing that is also similar, a little bit similar to diabetes. So being overweight and having what we call bad cholesterol, okay, and then not being physically active, okay, that also increases my risk. High salt diet, and I'll talk briefly about salt later, but also having diabetes increases my risk of having hypertension, which the two of them increases my risk of my kidney function going down, okay? And excessive alcohol, and then also, we know that it runs in families, okay? So I have cared for a grandfather, a father, and a daughter, and her worry is that, Rosalind, my children will also end up on dialysis, because we know that poor kidney health runs in families. And then genetics. So for us as Africans, there is a lot of studies looking at why Africans are at increased risk of kidney disease. And we know that those of us, especially from the West African descent, there is a certain protein in our body which normally helps protect us against sleeping sickness. However, what we know is that this protein goes through changes. And when we have one or two of those changes, it increases our risk of developing kidney disease or poor kidney health. Okay? Why do I care about this? Like I started from the beginning. Me, people like me, people of my color, develop poor kidney health. Now, what we find challenging and hard to believe is that as a person of black, my kidney health can go down 10 years more than the white person. Now, I've mentioned genetics as well. So it's not simply because we are not looking after ourselves, although sometimes that plays a key role. But we know that black people tend to have end-stage kidney disease 10 years younger than a white person. In King's College, where I work, 40% of the patients we look after are me. And that is why we care about that. The most important thing for us to know is that around the world, there are about 34% of people walking around with poor kidney health who do not know. And we'll look at why people sometimes do not know that their kidney health is going down. All of us know about what COVID did. And the fact that majority of the things we heard about COVID was black people don't do this, black people don't do that. There are a lot of factors that contribute to that, but we can see that even with COVID, people who had COVID and it was serious, who were admitted, when we compared them and now they have recovered and looking at their kidney health, we can see that more black people are now developing poor kidney health after recovering from COVID. Okay? So we really do need to look after ourselves. Now remember the vessels, the tiny filters that I showed, and I said, although it is good, sometimes the disadvantage of that is that early symptoms or early poor kidney health does not show until I have lost about 70% of those tiny filters. So people would walk around with poor kidney health and they wouldn't know until they have lost 70%. Those tiny vessels in the kidney, if we spread it out, roughly it covers about 10 kilometers surface area. You can imagine 10 kilometers, that's a wide surface area. But people having poor kidney health, nothing will show until they've lost 70% of that. Okay? Most of the time, people go to their GPs with one complaint, only for them to be told that, I am sorry, your kidneys are not working. Okay? What we see is a huge crisis approaching us because now people are living longer, but then we also know that there is increasing people with being overweight, diabetes is increasing, and hypertension is also increasing. And that is how that prediction is there. If we do not do anything, now, the number of people who will develop poor kidney health by the year 2030 would increase by 17%. So for us from Kidney Health, we have a mission. Together with us and then our kidney research companies, charities like Kidney Research UK, Kidney Care UK, we believe this is the time for us to act. And why do we think the time is right now? We need to act to protect ourselves, our family, friends, and our communities. Because it does impact on our ability to work. Okay? What do we use to check kidney health? Urine. Urine. As common as that, urine. Now, there is a protein that we look for in the kidneys. We look for in the urine. And if we find that protein, it means that the kidneys are struggling. In a healthy kidney, all that protein stays in the blood. But when the kidneys start to struggle, we see this protein in the urine. And ideally, they are not meant to be there. Okay? We don't only use that. We also check the blood pressure and the weight of the individual so that together we can measure how well the kidneys are functioning. How can I promote my kidney health? Well, my urine color says it all. So next time you are going to pass urine, remember this chart and then ask yourself whether your urine is smiling or your urine is asking you to add more water. Okay? Because our urine color says it all. Remember, the urine is coming from the kidneys. And if the urine color is that dark, it means that I am not getting enough water. Okay? What else can I do to promote my kidney health? First, what am I eating for? Majority of us do long days, and we close very late. But the question is, when I have done a long shift and I've closed very late and I go home, what am I eating for? Because if I have that big bowl of jollof rice in front of me, and I like jollof rice, if I have that big bowl of jollof rice in front of me, and I am eating around 8 o'clock, that jollof rice is just starch. It's just giving me energy. So the question I ask myself again is that, Roslyn, this night, what do I need starch for, unless I'm going to box? So that's the question we should be asking ourselves. What am I eating for? And also, why am I eating late? Okay. Salt. Is salt a friend or an enemy? And I can tell you, salt is not our friend. Salt is our enemy. A lot of people will say, Rosalind, if there is no salt in there, the food is not tasty. You see, naturally, every single food on planet Earth naturally has salt in it. Every single food on planet Earth has its salt in it already. But what we do is that we add additional salt. I don't know whether there are any pharmaceutical companies here, but you know what? The pharmaceutical companies, they like us eating salt. Because they are going to look for the next wonder medication that will help us to manage high blood pressure. Please, let's ditch the salt. And it is not just the salt that we put on our table, or pepper seasoning, Ajinomoto, Ajikama, Maggi cube, Raiko cube. Listen, let me say this. All those things, they are just salt. Full stop. People ask me, what about Himalayan salt? What about rock salt? Bottom line, salt. And salt is not our friend. Physical activity. Let's keep on moving. Every step counts. And I would not recommend going to the gym. And people say, Rosalind, why do you say that? First, it takes money. Second, it takes commitment. Majority of us don't have that. You have the tools right in your home. Do you like dancing? Turn on the music when you're doing your washing. Turn on the music when you're washing your plate. Just move. If you have stairs in your house, move up and down. Because you know what? Those are things we can do and incorporate in our daily activities than registering for the gym. Majority of people pay for the gym money, but they never go. So please, why pay? Stay at home, move around, run around in your house. That is easier. And if I have high blood pressure or I have diabetes, what can I do? And I always say this simple sentence, keep the numbers down. Whether it is my blood sugar, keep the numbers down. Whether it is my blood pressure, keep the numbers down. But it all has to do with what I am eating. And you can see the first thing there again is salt. What I am eating, and then my physical activity, okay? So we have a huge commitment, and we've made significant progress in identifying kidney disease at the early onset. But we want to make it a priority for our community. Because like I started saying, 40% of the people I see in King's College are me. And I want to make sure that there is increased productivity. So we want to create more awareness. That is why we are here today. We want people to see our community people actually checking kidney health. So we have trained people within the community who represent me, who check for kidney health. Okay. We use point of care system. So you get your kidney health results today. Within 5 minutes, you already know the status of your kidney health. And we would follow every person up if what we were expecting was not what we see, with your consent to get your GP involved. So I come to my final statement. It is an open invitation to all of us. Please have your kidney health checked today. Thank you.
Oh, let's give it up again. Kidney health. So in case you didn't get it the first time, salt is not your friend. So those of you who add extra salt after the live soup has been made, please make sure you stop doing that from today. Or the palm nut sweet or whatever it is you like to eat. I think it's a message to all of us, or those of us who like to eat hamburger, the young people, it's not just the elderly people. We go home late for work, we order McDonald's or KFC before going to bed. You need to check that as well. Just before we continue on, we're not expecting any fire alarm, but if it does go off, please use the exits here or at the back of the church there, and our assembly point is on the car park. In terms of toilets, if you go out this door here, come down, and if you turn right, the toilets are there, male and female as well. And before we continue, this is a community health day. So as mentioned before by our CHP president, we also have some clinical psychologists that will be available to speak to. We have Kazim Badmus, who is a clinical psychologist for trauma and behavioral counseling. And we also have our Rosemary Asante, NHS mental health advanced clinical practitioner. We also have, I think, our Food for Life people as well, just there, who will be talking to us about how to eat healthily. So our next speaker will be talking to us about breast screening. Darcy Schema, have I pronounced that correctly? Shimia. She'll be talking to us about breast screening. She is a health improvement practitioner and also a breast screening mammograph. Sorry. Yeah, there we go. Sweet as well. For Royal Shrewsbury Hospital. So please, let's give it up for our Darcy Schema. Yes. So 15 minutes. I think I've got time. Oh, sorry. How does this work?
Great, thank you. Okay, hello everyone. My name is Darcy. So I am the health improvement practitioner for the Shropshire Breast Screening Service. I am here today with one of our amazing breast care nurses as well, Deb. So any questions as well that you have after, please come over and speak to us. I'm going to speak a bit about breast screening. So what is breast screening, why we have it, who is it for, and what actually happens during a breast screening appointment as well. So a bit about breast screening then. It is a national programme. It is designed to find early signs of breast cancer. You don't have to have any symptoms to have your breast screening, and you also don't have to have any family history of cancer as well. So what a breast screening is, it is x-rays. They're called mammograms, and you'll have 4 x-rays done, 2 on each breast, and they're done by a female health specialist called a mammographer. So who is breast screening for? It's for all women aged between 50 and 71. You'll get your first invite anytime between the age of 50 and up to your 53rd birthday, and you have an invite sent to you by the post every 3 years. You have to be registered with a GP practice in the area. So if you're registered with one in Shropshire, you'll get called for our service. If you're registered with a GP practice in a different area, you'll be called to theirs. But what if you are over the age of 71? Not to worry, you can still have your breast screening every 3 years. You just stop getting a letter sent to you in the post. But if you call us up in the office, we can arrange that appointment for a convenient time for yourself as well. And breast screening is for anyone, no matter the size, shape, or density of their breasts. So who are we? Well, the mammographers, it's an all-female team. Everyone is a female that does the breast screening. We're a big team from lots of different backgrounds and different ages. And you can call us up, speak to us over the phone, or you can arrange a time to come down to one of our locations, come and speak to us. And everybody is really lovely and really happy to answer any questions that you might have. So why do we have breast screening then? Well, about 4 out of 5 breast cancers are found in women over the age of 50, which is why breast screening starts at 50 and we don't do screening under that age. And statistics have gone up, so now around 1 in 7 women will be diagnosed with breast cancer in their lifetime. So breast cancer is one of the most common cancers in the UK. However, regular screening can help spot early diagnosis. So early diagnosis means more successful treatment and higher survival rate. We know that the breast screening programme is successful because every year it saves around 1,300 lives in the UK. But it is really important, as well as your breast screening, to make sure that you check your breasts in between those appointments. So a bit more about checking your breasts then. So breasts are all different shapes and sizes, so it's really important to get to know what is normal for you. So it is advised to check your breasts at the same time every month, quite regularly, and you'll want to notice anything unusual, any changes. This could be in your breast, up to your collarbone, and also your armpit. So you're looking for things like lumps or a swelling, change in the skin, such as puckering or dimpling, change in colour or any changes with the nipple, such as an inversion where the nipple's pulled inwards, or a change in direction, any rash or crusting around the nipple, any unusual liquid or discharge, or any change in size or shape. We have some really good information over at our desk as well to show what the signs and symptoms look like on different skin tones as well. If you notice anything unusual, any changes, it is really important that you go and speak to your GP. Even if you're feeling well within yourself, even if you've had your breast screening done recently, if you notice any changes, speak to your GP and they can advise what to do onwards from that. But it is important to remember as well that most changes in your breast aren't sign of cancer, but you really need to speak to a GP to see and get that investigated further. So for Shropshire then, where and when is my breast screening? Locations, we are sited at the Princess Royal Hospital in Telford, Royal Shrewsbury Hospital, and we also have 2 mobile units, so you don't have to go into a hospital if you don't want to. We have one that goes around 7 different locations in the county. Currently it's in Ludlow. And then we also have another unit that is in the car park at the Princess Royal Hospital. Our clinics run Monday to Friday. And we do have evening clinics as well, so they go from 8:30 in the morning till around 7:30 at night. So if you're working or you're really busy, we can normally have a lot of availability, so we can find a time to suit yourself. The letter that you get sent in the post will have a pre-booked appointment, and I do think people think they've just got a letter from the hospital. It's going to be really hard. I'm going to have to wait months and months until I can change the appointment. You don't. Honestly, we have a lot of availability. So if the time doesn't work for you or the date doesn't work, then call us and we can reschedule. That's not a problem. If you have any adjustments, any mobility restrictions, or if you require a carer to come with you, or any literature in a different language or a different format, if you call or email us, we can also send that out to you. We're more than happy to help. So what will actually happen during your breast screening then? As I said, you'll receive a letter in the post with all of the details, so just make sure that you are turning up to the right location. It's very easy to get confused. And make sure you give yourself enough time for parking and transport. Once you've arrived, just let a member of the team know that you are there. They will then call you through when they're ready for you. They'll check your details. They will also see if you have any breast issues at the moment, and they'll run through what will happen for your appointment too. You'll then be shown to a private changing area where you'll be asked to get undressed from the waist up, including your bra. For the mammogram itself, then, you'll go through to the room and they'll place your breast in between 2 plastic plates ready for the x-ray. This bit only lasts a few seconds. They'll then take your breast off the machine, turn the machine around and do the same, so it'll be 2 images per breast. This bit only lasts a few seconds, but the mammographer is trained as well to provide support throughout this process. You can speak to them throughout the process as well, and you can also stop the breast screening at any point. Once that is all done, you'll then go back to the changing area, get dressed, and the mammographer will let you know when to expect your results in the post. A couple of weeks later, you'll get a letter in the post with your results, and these will also get sent to your GP, so it's as simple as that. So just a few frequently asked questions then. So what do I do if I've missed my appointment? Don't worry. If you missed your appointment and it was a week ago, if you missed your appointment and it was 6 months, a year ago, not to worry, give us a call again and we can sort that out for you. Another big question we always get asked is, will my mammogram hurt? No, it shouldn't be it might be slightly uncomfortable, but it just is the compression required for the x-ray images, but it shouldn't be painful. But again, just speak to the mammographer if you're slightly anxious or worried about this before the appointment. What should I wear during my breast screening? Well, wear whatever you feel comfortable in. We do advise that you wear kind of a 2-piece so that it's easy to get changed from the waist up. I'm really nervous and I have some questions before I attend. Who should I ask? Again, you can contact us in the office. We're more than happy to help. You can arrange to come down to the department or to one of the vans to have a look around beforehand if you would like. You can drop us an email. But also your GP should have all of the information about breast screening, so you can also contact them and I'm sure they'll be happy to help as well. Can I bring someone with me to my appointment? We normally advise that you don't bring someone just because the waiting rooms are quite small, especially on the unit. But if you do need extra assistance, a carer or a family member with you, just let us know beforehand and we can sort that out. But also just bear in mind that our waiting areas in the unit and in the hospital is a female-only space. So yeah, if you do have any questions, obviously we're here today to help and we can answer anything, and our email's up there and our telephone number as well. But yes, thank you.
Oh, I didn't need to tell you guys, it's just automatic. So yes, that was information about breast screening. So just to reiterate again, after all of our speakers have spoken, there will be time for questions and for further information. There'll be stands for each of the different topics that we've had today, so you can go to them and ask your questions and gain further information. Just a quick one as well, I mentioned we would have, psychologist speaking as well. So our clinical psychologist, Kazim Badmus, if he could just stand up so we can just acknowledge him and, know his face. So if you do want to speak to him later, you can speak to him. There he is. So we're going to move on to our next topic, which is menopause awareness. Women, are we here in the house? So those of us who want to gain more information about this, our Rachel Malcolm will be speaking to us about this topic. She is an advanced nurse practitioner, very knowledgeable about this. So let's give her a hand as she comes up and enlighten us on this topic.
Thank you very much. Yep. Keziah, have you seen my phone? Have you seen my phone? Are you sure? I can't find it. Have you seen my phone? Honey, where's my phone? Wait, I'll call you back, okay? I can't find my phone. Wait, I need to go upstairs. Okay. Mom, it's in your ear. I get this all the time. Where is salt? It's in the fridge. Today we are going to look at menopause. We have been privileged a couple of times as a church to look actually at this subject. And I'm passionate about this because you sit in that clinic and every time someone comes to you and they say, I'm not myself. I'm not, the way I used to be. I'm not as agile. You go to bed and your bones are aching. You wake up and your bones are aching. I thought sleep is supposed to be for rest. So why am I aching? What's going on? Sometimes I'm down, sometimes I'm up. I just can't do it. And it can be very depressive and makes women anxious. So, what is menopause is what we are going to look at today. And we are not going to go into great deal about the menopause, the menstrual cycle, what happens during the changes, effects of hormonal changes and management. And we have our own table there. So it will just be a touch-based thing, and afterwards you can come to us. I'm privileged today to be sharing a table with Dr. Chim, who is the obstetrician and the gynecologist himself. So when you come, you are privileged really to go deep into the subject and understand it better, because we have the person who knows how. So, I can't see that, but I can. So you have, menopause comes, any woman, when you reach the age of sometimes 45 to 52, we always say, or 51. But menopause can start earlier on. And there are other reasons why you can go into early menopause. And that could be because of surgery. It could be because you've had, breast cancer and you've been treated with chemotherapy. It could be because your womb had been taken out because of other things, or your ovaries have been taken out. And because of that, you go into menopause. But the natural menopause that we always look at is the one that you start between the age of 45 and between the age of 45 to 51. And with this, it comes with its own things. So it is the age that a woman really stops menstruating. So that's what it is. But it's a process, it's a gradual process. And that gradual process comes with its own things. And that's why I was making up that sketch earlier on, because sometimes you don't know that gradual process has started until people are waiting to stop their menses, but the process has already started and you're seeing symptoms and you can't understand what's going on in your own life. And like our brother has already talked about polycystic ovarian syndrome, that can also be an attribute for early menopause. And you can find people starting this even at the age of 30, at the age of, even young people, 16, 18, they can go through this. So just to be made aware today that, menopause, it's real. It is very real. Okay, so if you are a smoker or a drinker, or if you are very heavy, like I said earlier on, you are at risk of starting your menopause early. Symptoms would include a lot of things, and I'll just go by how I've divided it. And you could have what you call vasomotor symptoms, which includes, who has put on the heating in here? It's really hot. In winter, and you're very, very hot. And the next minute, you're like, where's the fan? Where's the fan? Because you have night sweats, you have hot and cold, you've got hot flashes, this heat that just comes as if someone has put heating on you, and you just want to strip. But it's all because the way estrogen works is that it has an effect on your hypothalamus and how heat is distributed within your body. So when estrogen drops, that is kind of, messed up. So that's why you have hot flashes here and there. I'm trying to put this in the simplest way as possible that everybody can understand. So it often starts about 1 to 2 years before you actually go into menopause, completely stop your menstruation. And it can go on and on and on and on. And duration can be about 7 years you're going through this. This is my kind of thesis, because I'm looking at how can we help each other manage this period where you experience hot and cold. Severity depends on each individual. You cannot say, oh, I did it. Some people don't even go through it. Some people do. And you will never know. Some people will experience other symptoms, but at the same time, that's why we are here today, to make sure that we empower each other and we are knowledgeable in how to manage this. So then you've got symptoms where women would complain about, you could have dryness down below, because we've got kids in the building. And also you have women struggling really with a lot of issues. It could be urinary tract infections. It could be, even in a marriage, you are struggling because of this effect of what we call vaginal dryness or vulva issues. So with that, we will talk about it. If you are one experiencing that, just come to the table and we are going to talk about further. We are also, psychological changes that happens, you are anxious, depression, indecision, anxiety, fear of unknown. Why am I fearful all of a sudden? I used to be someone who's agile, who's jumping up and down, but all of a sudden, any little thing, oh, what's going to happen? What's happening to me? Oh, and every time you're going through this and you're wondering, why? Sometimes we need to check. It could be menopause. Irritability, hey. He says, that woman, she's hot nowadays. You can't sit beside her. You know, any little thing, what is wrong with you? And this can really cause a lot of problems in a marriage, especially because you don't understand each other. This nice, lovely lady who used to be really calm and quiet, and now she's just become something else. You're like, I don't recognize you, you know, because of the changes that have been brought upon by menopause. Insomnia, a big issue, and it has impact on kidneys, it has impact on diabetes, it has impact on so many things, everyday work. But you'll find that in the middle of the night, for no reason, you're awake. And no matter how much you try, you can't sleep. Now add that to hot flashes. Add that to pains in your body. So everything works together, and I'm glad for everyone who has already presented, because menopause has impact on all these areas. So really, it is important for us today to sit down and have a chat. We are going to look at how we can prevent some of this: forgetfulness, brain fog. We are also going to look at how we can, we were trying to get someone for MSK, unfortunately we couldn't, but sometimes menopause can have an impact so much on our musculoskeletal functioning, and that is because of the depletion of estrogen. So musculoskeletal symptoms would be joint pains, muscle aches, back pain, and also acceleration of bone loss. So you find that a lot of other people, even a small, fall like this, already you've broken a bone. What's going on? Sometimes it could be because of menopause. So lifestyle changes, do they really help? And that's what we are expecting that desk to tell us today. And also, lifestyle cuts across everything. Our kidney specialist Ness has talked about, it also has an impact on menopause. Everything that, our brother is going to talk about, diabetes, it has an impact on menopause. Any lifestyle change that you can make has an impact on menopause. And the big issue also right now is talking therapies. So I believe that our psychologists and all that who are in the building are also going to talk to us about it, because it helps us manage our understanding and how we can ourselves help ourselves in managing menopause. Going forward, as I said, with every lifestyle change, comes with also things that you can help yourself, because really, when we come to medication management, it's not everything that can be sorted out by a pill. And not only that, you have to be streamlined to be able to get on that pill. So if you are looking for HRT, you still have to be screened if you are eligible for that. So you could be someone who think, okay, I can just go on HRT, but are you a person who's eligible for HRT? So all those things, but understanding how you can manage yourself, you can manage your own lifestyle is very important. Because even if you go on HRT, it has its own things that it comes with. So it's very important that we understand how we can manage our own lifestyle to also affect our own outcome, our health outcome when it comes to menopause. So still on that. So you've got treatments that can come with, which are non-hormonal treatments. So you've got CBT, which is just talking therapy, where you can go and sit with people, especially when you're experiencing anxiety, depression. A lot of mental health issues can come with menopause. And your GP, when you go to your GP, they should be able to signpost you to talking therapists, which is a service that has been established Every GP just ask for talking therapists, and it is free of charge, and they will refer you to them, and they will contact you specifically to talk about. Menopause can really, for those who really get it bad, it can even lead to suicidal ideations. So you feel like, no, life is not worth living, and all that kind of stuff. And if you're experiencing something like that, please do not leave today, and make sure that you talk to someone. So I'm not going to go much into this, but treatment of brain fog, like I said, you could have HRT prescribed by your GP after you've been screened, appropriately screened to be on HRT. And also try and get enough rest. You know, I remember going to a meeting and completely forgotten where I'd just been. And I'm there trying to make this report, and I'm just like, I can't remember. It's really bad. When you get it, it's really bad. And thank God I had someone there, and it's like, we went to this place, and you mentioned the name. So since then, I started saying, you know, if I forget anything, just jump in. And you know, it can affect you. If you're a person who talk a lot, who do a lot of presentation, you can stand there and completely forgot what you were supposed to say. Because menopause is real. Somebody say, it is real. It is real. Okay. So very important that we change our diet. Diet is important. And it's not about weight loss. It's not about, because if you diet, you will get tired and you'll stop. But let's go to healthy eating. Because whenever we bring the word diet, then it becomes a problem. I have to stop this, I have to stop that. But hopefully today, by the end of the day, we'll understand what healthy eating looks like. There are also natural options, but a lot of these have not been tested and tried. And when you go to Holland and Barrett, or you meet some people, they will tell you, oh, try this and try this, eat turmeric, eat that, vitamins and all these things. Most of these things have not been tried. And a word of caution, especially to us who come from Africa, your mama will say, this helped me. The problem with those things, they've not been tested. What it is doing to your kidneys, you don't know. What it is doing to your blood sugar, you don't know. What it is doing to your blood, to your heart, you don't know. And it's because no one has really measured and seen the effect of it. It will have a knockoff effect on something else that tomorrow, now we are going to start treating that thing because. So it's really, really important that we avoid self-medicating ourselves at home and really go and see a professional and discuss this issue of menopause. There are things that people will tell you that they are local effects, and if you apply this and you do this and you do that, you end up burning yourself and then you create a bigger problem. So it's really important that even if you have that thing, if you go to NICE guidelines, they have recommended some things, but they also say that this has not been tested properly. So if women are using them, you use them with caution. Okay, so a lot of things you can take your vitamin D. It's very important, as you hear, you know, with every woman at the age of 50, really, we should be taking vitamin D. When last did you see the sun? I'm even surprised because it was supposed to rain today. Oh, not, let me not mention that. So it's very important that we take our vitamin Ds because we are not exposed that much to the sun in the UK. You could have gotten away with if you live in the tropical regions and Himalayas and, you know, you go to Turkey every week if you can afford it and, you know, lie in the sun. But it's really important that we take our vitamin Ds. Our vitamin B, very, very important at the same time. Vitamin C, it helps us with our immunity, building up our immunity and all that. So really, if you need help in identifying what you need, the desk is available today so that we can all look at this together. And lastly, I'm just going to go to the end and will not talk about HRT because no one is here to really talk about medication. But if you think that's the line you want to go through, then you can go through your GP. I'm just going to look at some of the websites which are really, really important, and they are very, 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 very beneficial. And if you want to explore, could it be menopause? You can find it at Primary Care Women's Health Forum. You can go in there. You've got NHS website, nice guidelines, which helps us as professionals. You've got the British Menopause Society. But the main one that you can all access is the last one, the bms.org.uk. And everyone can be helped and supported. Another thing before I leave is there's no blood test that will tell you that you've started your menopause. Because during perimenopause, your hormones are all over the place. And the day you go to your GP to ask for that blood test is the day your hormones are really high or are really down. So there is no point of you going to your GP and asking for a blood test to test whether you have menopause. It's mostly symptomatic management that we deal with. Unless you've actually started your menopause, it can now show that yes, your levels of follicle stimulating hormone levels have gone down, and that's the only time now you can really establish yourself that you have menopause. So now I've come to the end. I hope I can find my phone and I can find my seat. And please put the heating down. I beg, it's too hot in here. Thank you very much.
Up again. So just before we move on to our next topics, again, we just have a few people that we want to introduce. So we have our Dr. Gordon here with us. If you'd like to stand and just wave. He's the area head for CHPNet, so for Birmingham area, which we are part of. He is based in Wolverhampton. So if you have any questions after this discussion session has ended, please, you can talk to him as well. And also our Rosaline, our house, the lady who talks to us about kidney health, she came with a kidney team. If they could stand up, they're wearing the purple t-shirts. She also came with Dr. V. So if you have any deeper questions, please, you can go to them at the end. We also have our nurse, Rosemary Asante. So she's also part of the mental health team. She could stand. So when we are done, if you want to speak to her. And then just once again, those who have just arrived, if you need to go to the toilet, through this door, down on your right, no fire alarms expected, but if one does happen, out the doors on the back and here at the end as well. So our final topic is diabetes awareness talk, and we have our Dr. Roland Taylor to speak with us today. He is currently undertaking his higher surgical training in the Yorkshire and Humber Deanery of Health Education, England. And his specialised area of interest is complex, metabolic and weight loss surgery. So please, let's give it up for our Dr. Roland.
What do we use for the slides?
So that's to go forward.
Oh, okay, that's fine. Okay. All right. Good afternoon, everyone. Thank you very much for having me. I've been given two topics to talk about, diabetes and then prostate problems. So I'll try and make it as quick and brief as possible. And then one of the most difficult things to do is to talk to people in the church, because you have people of all kinds of expertise in there. You have people who know more than you do, people who don't have any knowledge about what you're about to talk about. You have people who don't have any knowledge but do not know that they don't have any knowledge. And so you have to deal with all these groups of people. So I hope that at the end of the session, we'll all be able to get something from it. My name is Roland, as I've been introduced, and ignore the rest of the things that were said. So we'll talk about diabetes first. How are you doing? Yeah, that's fine. Come on. some help here, man. Oh, is it? Oh, sorry. Is it too... Am I too much in a hurry then? Oh, okay. Which one? This one here. Oh, that one? No, the top one. Okay, all right, that's fine. Okay, all right. So, so diabetes, essentially, let's do some definitions. So diabetes is essentially a chronic disease. So chronic means something that stays with you for a very long time. And it's also a disease of metabolism. Metabolism is just a fancy word for breakdown. And all of this results in excessive amount of sugar in your bloodstream. So essentially, when we say someone has diabetes, we're saying that the person has a chronic metabolic disease that's characterized by elevated blood sugar. Now, in some of the talks, a few things have been mentioned. So you do have a gland called the pancreas gland, which is somewhere behind your stomach, which is responsible for producing something called insulin. Now, most of the foods that we eat are broken down into complex sugars as well as simple sugars. Now, the insulin is supposed to help you to transport these sugars from the blood to your cells so that your cells can use them to function. So if for any reason this function doesn't happen, then there's a lot of the sugar remaining back in the bloodstream, and that's what's classified as diabetes. So the things that could possibly go wrong are that you do not have any insulin, or you're not producing enough insulin, or the insulin that you are producing is defective, or where it's supposed to go and act, it's not being able to act there. So it's based on these two sort of broad classifications that we have the types of diabetes. So essentially, as a rule of thumb, we will say that people either are type 1 diabetic or type 2 diabetic. And type 1 diabetic generally will require the use of insulin because most of the time the reason for their disease is either they are not producing any insulin at all or they are producing little amounts of insulin, so they need some help with that. And it stands to reason that for these people, their treatment will be to give them insulin. And it's a type of diabetes that you would usually find in very young people. This time we're having them in very, very young people, people as early as ages 8, 9, 10. When you go to highly specialized centers, you can have people having diabetes in those ages. Type 2 diabetes accounts for about 95 to 90%, 98% of all diabetics. And that's the one that is more associated with lifestyle, essentially. And there are certain risk factors that are associated with them. We will talk about that. So when you go to most populations, if you have 10 people that are diabetic, 9 of them will probably be type 2, and you probably find the one odd or so person who's type 1. Now, also generally as a rule of thumb, people with type 2 diabetes are usually treated with tablets, but then sometimes you have to augment it with insulin as well. So it's just sort of a broad classification for us, All right. Now we need to mention special mention of some other types as well, and they've been mentioned briefly. So there's something called gestational diabetes. So gestational diabetes just talks about diabetes that can occur in pregnancy, and usually happens from about the second trimester, and they carry on until term. For a sizable number of the mothers, once they deliver, up to about 6 months after delivery, their blood sugars can return to normal. But definitely it is a risk factor for development of type 2 diabetes. And for many, many people, actually, that is the first instance at which we find out that they actually do have type 2 diabetes. Another consequence of it is that people who tend to have really big babies. So if it's mentioned to you in any way, once you are pregnant, you need to be cognizant of that fact and then think about ways of delivery at the time of delivery. There's also pre-diabetes, which was mentioned briefly as well, which talks about you sort of having blood sugars that are high or highish, but not sort of at the level for which we say that you are diabetic. And it's also known to be a risk factor for development of type 2 diabetes in later life. So let's talk about the risk factors for development of diabetes. So for type 1, unfortunately, there's not really much that you can do about it. It's sort of, if you have it, then you have it, essentially. You can't really do much about it because there's a bit of sort of familiar association with it. And actually, it's been noticed that when you do have very close relatives that are type 1 diabetic, the likelihood that you have it is slightly increased. So if you have a father that has type 1 diabetes, you have like a 1 in 15 chance of getting it. If you have a mother that has it, you have a 1 in 40 chance. I don't know why, the difference. If you have a twin, sort of a monozygote twin who has it, then it increases to about 1 in 2 or 1 in 3 chance of getting type 1 diabetes. Essentially, you can't do much about it. You can't change who gave birth to you, and you can't change where you came from, isn't it? Type 2 diabetes is the one that we can do something about because there are risk factors. Some of them are modifiable and some of them are not modifiable. So the risk factors that you can't do anything about are increasing age. So usually above the age of 45, unfortunately, we can do things to change our appearance, but you can't do anything to change your chronological age. Also, your race as well. So it's been found out that people, Hispanics, and also people also from South Asia, and then us as Africans as well, we have a slightly increased risk of that. Now, the things that we can modify include obesity. So if you're a bit on the heavy side, then your chances of getting type 2 diabetes is a bit on the high side. Reduced activity, so not being very active. And most of us have jobs that we tend to do a lot of sedentary stuff, so we are not active, and that increases our risk of that. We've already mentioned pre-diabetes, and then we've also mentioned gestational diabetes as well, as all being risk factors of that. All right, so how will people present with diabetes? So most people, the first class, probably rather than say asymptomatic, we'll say incidental. So most people, we tend to find out because they've come to hospital for something else. So somebody is coming to have some form of elective surgery or something, and then as part of the basic test, they check the blood sugar and they're like, oh, hold on, this is quite high. And then you institute a mechanism of checking it over a period of time, and then you find out that it's been high for a bit, and then they are diagnosed as diabetic. Some may also present with the classical symptoms of either feeling more thirsty every time they come in complaining about drinking loads of water, feeling hungry even after they finish eating, waking up at night to urinate most of the time. These are all things that could be as a result of other things, but diabetes should also be considered as they could be the cause for that. People may become a bit more lethargic, weak, not as active as they usually are. And then some people also present with the complications of diabetes. And diabetes, when we do get to the complications, you will see it's a systemic disease that can affect every part of your body. So people may come in with either complications of high blood sugar or low blood sugar. So may have come in collapsed or may come in with really high blood sugar, or either complications such as a stroke, or may have an ulcer on some part of their body that is not healing and things like that. So there are many ways in which people can present to the hospital with diabetes. To be able to make the diagnosis, usually we test your blood sugar, and there are different tests that are done. So there's a test that can be done for you after you've had an overnight fast, which is called the fasting blood sugar. There's a test that can be done for you 2 hours after you've had some food. And then sometimes there is a special test that you are given some amount of glucose to be able to take, and then after a period of time, they check your sugar. All of these things have reference ranges, and then based on the ranges, we're able to tell you whether you think you are diabetic or not. So once we've made that decision, then what do we need to do? So we need to manage it, essentially. We've said that it's a chronic condition, and chronic conditions are not conditions that you're able to necessarily sort of treat completely. What you do is that you manage them so that they don't give you any more trouble that they've given you already. So what do we do in terms of, first, modification of risk factors? So we've talked about the risk factors that we can modify. So things like your weight, increase in activity, smoking, drinking. These are all things that you cut down on to be able to help you and then reduce the risk of getting complications from this. Also, there's dietary use in the management of diabetes. And most of the time, the nutritionists or the dietitians will talk to you about. And it's apart from getting you to sort of stop taking some form of complex sugars, usually it's more about portions and the frequency of having them rather than stopping sort of exact amount of foods. Because most foods essentially will be broken down into sort of complex and simple sugars anyway. And then there's the use of medication. We've already mentioned that type 1 diabetics will usually have insulin. Type 2, most of the time, will have tablets, and sometimes will be augmented with some insulin as well. And then for some people, their diabetes may be such that you may need a host of all of these things to be able to manage them. So you are doing dietary control, you are giving them medication, they have to do lifestyle modification. And then for those who also come into hospital with the complications, if you come in with a stroke, we have to deal with it. If you come in with a very bad ulcer on your leg that requires an amputation, we'll go ahead and do it. If you come in with blocked vessels that need revascularization, we have to do it. So that's what happens for that. In terms of complications, I've put this diagram there just to show that diabetes can affect every part of the body. So if you go all the way from the head all the way down to the toe, because you have vessels everywhere in your body, and you can have blockage of these microvessels. And once enough blood is not getting to any tissue or any organ, it can die off, or you can have pain in that organ. So if you take your brain, if the vessels in the brain are blocked, you can get a stroke. Okay. If the vessels in and around your neck are blocked, you can get what we call a TIA, or you can get what they call a mini stroke. The vessels around your heart gets blocked, you can get a heart attack. Also, in your stomach, people who have diabetes sometimes can develop what we call gastroparesis, where they eat and their bowels sort of don't function as quickly as they should. So there's a very sort of, that gastric emptying time is more prolonged. You can have problems with your kidneys, as been mentioned. One of the leading causes of kidney problems in the world is people who are diabetic. Also, because of the problem with microvessels, people tend to get ulcers on different parts of their bodies that you struggle with the ulcer to heal. So you get non-healing ulcers, and sometimes people may even have to have amputations because of this. Also, because of reduced immunity, you tend to get infections everywhere in your body. So you get a lot of oral ulcers, you can have tooth problems, balls everywhere on your body. So it's sort of everywhere. That's why once we've detected it, it's very imperative that we try and put in a mechanism for managing it for you so that you do not get to the stage where you get all of these problems. How can I prevent diabetes? Well, we've mentioned it, in terms of modifying your risk factors. How often should I check your blood sugar? A regimen will be put in place for you by your GP or whoever is sort of managing the blood sugar for you. And it's all dependent on where you are in terms of your management and what kind of symptoms you are showing and what you require. What should you do if your blood sugar is too high or too low? You need to seek the appropriate health guidance. So obviously, if it's too low, it's very problematic because that you can present with collapse, and very, very low blood sugar is really not compatible with life, and it's really, really bad thing because it's very, very easily reversible. You know, if we give you adequate blood sugar, you can get back and be walking up. And so once you have any of these things, you need to seek medical help. Should I get a medical alert bracelet or a necklace? Yes. That's, I don't know if all of us here do know about it, but it's very important, especially when you are out, because when somebody comes to find you collapsed somewhere, I mean, we'll try all sorts of things, but then if you do have a bracelet that says, I'm diabetic, then one of the first things that they'll think about is, has this patient sort of had low blood sugar, and can we sort of correct it quickly? And it's very, very helpful if you travel out of this jurisdiction as well, because they are universal and people are able to sort of read them and then know what are there any vaccinations that I can or cannot get? Not necessarily. None have been sort of proven that because of your diabetes you can have it. And this is a question that comes up since COVID, so we just put it in there. How should I take care of my diabetes when I travel? Is bracelet informing your travel agency, and if you are in trouble, go to hospital. All right. We'll quickly talk about prostate. The second part is to talk about prostate problems. So the prostate gland is a gland that is found in genetically male people. Nowadays, we have to use that because, you just have to be sure of what you are talking about. So you have to be born male to have it. Now, you do have it when you are born, and it sort of develops and grows to become a bit bigger over time. In terms of its position, so it's sort of found below your bladder and then in front of your rectum, and then it sort of encircles the top part of something called the urethra, which is where urine sort of passes through. And the reason why we mention this in this form is that sort of gives you an idea as to what kind of troubles outside the prostate itself that it can give you. Because of where it is, if it enlarges, so it's below something, so it can enlarge to go into that. It's in front of something, so it can enlarge to push onto that. And it encircles something, so it can also enlarge to compress on that. So those, if you don't take anything from this, I think that's something that you should take. So those are the three cardinal things that it's about 30 grams in size. Walnut, nobody really cares about that, to be fair. All right. Okay. Now, what does the prostate do? So the main function of the prostate is that, so in males, genetic males, so you're producing the sperm. Now, for the sperm to be able to travel where it goes, your prostate produces something called seminal fluid. And the seminal fluid sort of serves as a medium to help in the transport. So that's the main function of the prostate. Now, disease of the prostate. So disease of the prostate can come in two forms. And mainly, it's as a result of increase in size. So the prostate grows bigger. And once you are growing, the prostate increases. Just like many other parts of our body, you get an increase in size of the prostate as well. Now, you can have an increase in size of the prostate, which is non-cancerous, what we call benign, but can still cause you problems. And then you can have an increase in size of the prostate, which is cancerous. Okay? Now, because the primary thing that happens is that the prostate has increased in size, in terms of the symptoms that do happen, they are not, you can't really differentiate one from the other based on symptoms. So most people who do have prostate problems, especially if it's early prostate problems, won't have any issue at all. Because you are 50, you are 60. I mean, the urine was doing that before and is doing that now. Yeah, well, it's just like everything in your body. Things slow down, so you don't really pay sort of much heed to it. But the symptoms that sort of tend to happen are usually what we call obstructive symptoms. So if you think about it, because it's sort of encasing the top narrow part of the urethra, when it compresses on it, the things that can happen are things to do with going to pass urine. So either you go to pass urine and the urine is dribbling, or you go to pass urine and you cannot pass urine at all. Or sometimes what will happen is that when you go to pass the urine as well, you may feel that you haven't sort of emptied the bladder completely and you need to go back again to pass urine. These are all things that will happen for somebody who has an enlarged prostate. Now, if it's caused by a cancer, and the cancer is advanced, then sometimes you can have some other symptoms that are out of the prostate. So things like pain in your back, because if it's sort of gone to your bones and things like that. People may also complain about things like night sweat, so sort of the things that the females in menopause feel, but males, you sleep at night, there's nothing happening, you wake up drenched in sweat. For no apparent reason, there's sort of decreased appetite and sort of a bit of lethargy and all of that. So those are the things that sort of are, well, if you do have urinary problems and you do have that, then we'll worry whether or not you do have a cancer. Now, what are the risk factors? So the risk factors, everybody for getting prostate enlargement is being male. If you are female, unfortunately, you have missed this one, or fortunately. Being above the age of 40 as well. And then also for the cancer, black males, obesity, and then also smoking as well. And then if there's a family history for prostate cancer. We've already mentioned the presentation as well. So frequent urination at night, difficulty in urination, slow dribbling urine, need to urinate urgently, blood in urine as well sometimes, weight loss, night sweats, back pain, and then other symptoms of spread. So if it's gone to other places like your lungs and other things, then you may show symptoms from there as well. What do? You need to visit the healthcare professionals because there are people that will be able to help you. What we try and do in these talks is that we don't try and talk too much about treatments because we don't want to substitute the healthcare system for any of that. Are there any routine tests on the NHS for the prostate? The answer to this question is yes and no. So there isn't any properly so-called screening program like you do have in the breast cancer or bowel cancer, but they have this screening, I think it's cancer risk screening, and if for males, you have to be above the age of 50. And then you go and then they check your PSA. Now, the reason why it's not sort of a well-documented cancer screening, because for any program to be sort of agreed on as a screening program, you need to satisfy a few criteria. So you need to sort of determine the disease burden. It has to be a disease that is troubling a lot of people. You need to determine the age for screening. And these are sort of, these two tick for prostate, but the test that needs to be done needs to be sort of simple and agreeable to the populace, and then the results need to be interpreted by all. Now, for prostate, the very easy test that you can do is the PSA, but PSA is not specific for cancer. So the PSA can go up in many other instances, so infection, other things, if you've had a biopsy, you've had other things in and around your prostate, or you've had some form of a bad urinary infection or a prostatitis, it can go up. So it's not very specific. What is, however, specific is to do a biopsy, which you have to do through ultrasound guidance by passing a needle somewhere through the bum. And I don't think that people are happy with that. So that is not something that has been agreed on. So if you're over 50, you can go and get your PSA tested, but with the knowledge that PSA is not very specific for that. And after that, we can do some other tests. The PSA, if it's very high, sort of in the 400s or thousands, then we do worry that it's cancer. But if it's just slightly elevated, it's quite difficult to interpret. Is prostate cancer hereditary? Yes, there's some familial elements in it. So we notice that if there's a close family with prostate cancer, then your chances of getting it are high. And then sometimes for some other cancers as well, if you have them in the family. So thyroid, breast, as well. If you have those in your family, then the incidence in the family is quite high. Can it be prevented? Well, there's some controversial studies that they think that people who have, still in church, right? People who have a lot of sex can prevent prostate cancer. Now, it's not, the jury is still out, because what they think happens is that with every ejaculum, you can take out some of the cancer cells. Whether it's true or not, we don't know. So, but because it's there, people have done some studies, and it was done in a very reputable institution in Harvard as well. So we're still looking at it, and we'll see. Will I have erectile dysfunction if I have prostate problems? Yes, you could. You could. We've mentioned the role that it plays in terms of the seminal vesicles with the sperm as well, and then also some of the medications that are used to treat BPH also can cause erectile dysfunction. I believe I've come to the end of my talk. Thank you very much for listening to me.
Oh, one more time. So, our final discussion or presentation will be Food for Life, brought by Golden Life Health Limited. We have our Dr. Eric Danso-Boateng talking about us for Food for Life. He is a preventative health advocate, a lecturer at the University of Leeds, and specializes in chemical engineering. So here he is to give us a brief presentation.
Okay. Thank you very much. Yes, I know you're already tired, but give me some time, just 10 minutes. I'll try my best to finish. And I'm very happy that all the previous speakers have talked about lifestyle. And I'm sure most of you want to know more about the lifestyle, so that's what I'm going to talk about. And I was very intrigued about Rosaline's presentation. That's my daughter's name, by the way. Yes, she talked about kidneys. Yeah, so I was very impressed. And also, I enjoyed the menopause side as well, though I'm a man, forgive me. Yes, because that is also linked to lifestyle and, of course, prostate and diabetes. So all of them are linked to lifestyle. So just waiting for the slides to be ready, then I will just begin my presentation. So just as she said, I am a chemical engineer, and it's one of the diverse engineering areas. So don't be surprised if I'm talking about preventive health, and that is something I've taken upon myself to help other people to be aware of how to live in a good lifestyle so that they can avoid a lot of troubles. Yeah, we are still waiting for the IT man to fix us. Should I talk without it?
The pen drive is not picking it.
Oh, let me. Should I?
Sorry, just bear with us whilst we resolve the technical issue. There's a pen drive, but I think it's not picking up, so please bear with us. It will soon be lunchtime, so don't get too hungry. We've heard a lot of things about food, so there's more food coming. I tell you what, Mr. Rosemary, you want to share a little bit about the processes for the screening? Is that okay whilst we wait for the technical issue to be resolved? Thank you very much. At least she will give us insight as to the processes and what we need to do whilst we finish the lunchtime. Is that okay?
Thank you very much. Now, if you remember when I was talking, I said the kidneys and the heart work together. So although we are going to ask people to give us a sample of their urine first, because we are asking you to give us a sample of our urine, we would need you to sign that it is okay for me to take your urine. Because sometimes people ask, Rosalind, why have you given me a form to fill? I've taken your body tissue, which is urine. So I just need you to sign a form that it is okay. On the form, we would also collect a little bit about your medical history. So we'd ask you if you have any high blood pressure or diabetes, and then if you are taking any tablet, we would record all of that on the form. It helps us to look at your urine health outcome and then map it whether it's because you have diabetes, that is why your urine is that way. And it also helps us when we are working together with you and your GP with your consent, how to ensure that you get the best treatment for you to ensure we maintain your kidney health. So we would ask you to check your weight, check your height, and then give us the urine. But please remember that there is a paper that you need to sign, and then sign it, please. If you cannot remember your GP practice name, even if you can just tell us where it is, we'll be able to find it. But these are important. Why do we ask you to give us your GP details, especially if the urine check or the kidney health is not what we expected? We would like to work with you and your GP to make sure that we promote your kidney health. That is why we ask you to give us your GP details. Some people will say that, Rosanna, I don't have a GP. Can I still take part in the test? And we say yes. Well, if something happens, what then we would do? We would look at, remember, I am a nurse as well, I work in King's College. So we'll look at what else could we do to make sure that we promote your kidney health. But if you have a GP, we would appeal with you, please put your GP's details down. We would also ask you to put down your mobile number. Why is that important? So that if I need to contact you about any further outcome, I would know who I am speaking with. That is why we are asking for these details. People will say, are you sure these details are not going to go anywhere? Every detail that we collect stays with us, just the research team. So, and when we finish with the test, although you would have other supporting team working with us, all your details just stay with myself and Rachel and the rest of the team. Rachel, are you here? Okay, so all your details just stays with Rachel and myself and the rest of the team. It doesn't go with anybody. We go with it. People have also asked me, the urine that I give to you, what do you do with the urine after the test? So we take the urine away, we take it all the way to King's, and we put it in the clinical waste. We do not store your urine for anything. Once after the test is done, your urine goes in a recycling bin, we discuss it. Because people are asking me, do you use it later for further research? We cannot use your urine later for further research without your consent, but the urine we collect, it ends up today going in the clinical waste bin. So I can assure you of that. So you can see that the process is a little bit longer because you have to fill that form. So please, as we are ushered to come in, do bear with us. We have 4 machines that we are working on. So there will be 4 people working on the urine test at the same time, and then there are 4 people checking the blood pressure at the same time. So please do bear with us. We would ask you to take off your shoe just for you to check your height. The reason we ask for that so that you don't steal any height and become taller than I am. Also, when we are checking your weight, we want you to take your shoes off because sometimes your shoes are a little bit heavy. But that is what we'll do. So we have to do weight, height, blood pressure, and then we ask you to give us the urine sample so that we do the test. Now, you would go with your kidney health check test as we said, literally within 2-3 minutes, the result is out. So you would leave today with your kidney health outcome, knowing exactly what it is. There are people who said, okay, I want to know, but I don't want to know. And then I said, okay, why do you say you want to know, but you don't want to know? I would rather I know so that I do something. And for most of the patients I see in Kings, they always say, Rosalind, I wish I knew. I would have done something. So knowing causes no harm. However, I've also known some people say, I'll be stressed about knowing it, then I'll not be able to sleep thinking about it. We are here, we work together with you, and we have one-to-one follow-up if the result is not what we expected. And I can assure you, I would rather know than not know. Thank you.
So I'm just going to break protocol. Moderator, permit me to just allow 5 minutes from Food for Life, and then we'll start our break. Is that okay, please? Bear with us. 5 minutes.
Yeah, thank you, Josh. For some reasons here, I think we are all hungry, so we need to just make things snappy. So we are Golden Life, and we are based in Birmingham. Our vision is to help our communities to understand the importance of healthy lifestyle and, of course, the science of food. And we are in partnership with International Diabetes Federation to create the awareness of type 2 diabetes. All what we do is that we go and shop, we buy groceries, we buy organic, but to get the food in here, it has to pass through stages. We need to prepare the food, washing and all that. We need to cook it, and we eat it. And when we are eating, we want to normally achieve certain things. For instance, most of us will be thinking about the taste because that sensory characteristics determines the kind of food we want and what we want to eat. So we want to maintain a certain taste. We also want to eat to get energy because that is what keeps us moving, and we get that from the carbohydrates. And we need to get the nutrients from the food too, the micro and the macronutrients from the food. And we can lose the nutrients and even the taste and even the energy if we don't prepare the food the right way. We can also pollute our food. We can add contaminants to our food during the cooking process if we don't use the right cooking system. Because the cookware we use at home are made of metals. We use metals to manufacture them. Whether it's an alloy like stainless steel or it's a pure metal like aluminum, they are all metals. And those in the sciences, we know that most of these metals, we call them heavy metals, have bad health implications. Aluminum, for instance, is linked with dementia and Alzheimer's disease. Yes, and also other metals contain cadmium, lead that are linked to kidney diseases. We don't see that we are getting this into our food, but the food reacts with it. For instance, tomatoes is acidic, and it will react with the metals, and the metals will leach into our food. So you see that you may be cooking your own meal. You are not eating junky food, but you end up getting lifestyle diseases, and you're wondering what is going on. Why is it that I buy organic? Why is it that I eat my own food, but I'm not getting well? So a lot of factors contribute to this, and that is what we help people to prevent. And once you get these skills, or the art of cooking, and you understand the science of food, then you'll be able to get the benefit of the food you spent money or the groceries you've spent money to purchase. So that is what we do. And as I mentioned previously, when the slides were not working, you could see that all the previous speakers talk about lifestyle, and they talk about the food we eat. If we get the right nutrients, even the menopausal symptoms may be minimized because we have the right nutrients in our body. If our food is not contaminated, we may be able to reduce symptoms of kidney diseases because we don't have heavy metals in our system. And of course, diabetes. And all this lifestyle disease, we call it lifestyle because if you put genetics aside, most of these are obtained from our lifestyle that we chose. If we are not able to control our lifestyle, then we are likely to get one of those lifestyle diseases, and they are also linked to each other. Rosalind talked about it. Getting kidney problem can also lead to something else. Having diabetes can lead you to hypertension. Hypertension can lead you to diabetes, etc. And the medication that is given to us is for cure, but it doesn't prevent diseases from coming to us. The prevention side is what we have to do, our lifestyle. Okay, and if you take the medications for a long time too, they also come with side effects. And some of the side effects are also serious lifestyle diseases. So if you've been taking a diabetes drug or hypertension, you will see that you go for routine checkup of your kidneys and livers and all that because of the medicine that has been given to you. So that is how it is. We are at the preventive side. Our stand is over there. If you want to understand the art of cooking, if you want to understand the science of food, or which we always do, we do. So just understand how you can do it proper so that you get the full benefit of it. Thank you very much. I won't take much of your time.
Okay, let's give it up one more time. Thank you so much for bearing with us. We've now come to the end of the presentation side of things. So we're just going to go into a quick lunch. But when we have the lunch, please don't go, as our nurse, Rosemary said, they've got the kidney screening happening. We've also got different tables, different stands for all the different screenings and information. So we've got cancer awareness here, we've got diabetes awareness here, food for life there. I think we have the PCOS on this side as well. So please don't go. When we've done with the meeting as well, we've also got counselling as well. As I mentioned, we have some clinical psychologists there to talk to. We also have our pastor, Emmanuel Addo, if he could stand, and our Sofmame, Delphine Addo as well, who is a trained counsellor, if she can also make herself known. So if you want to talk to them, gain some advice, you can do as well. So let's break for lunch, and please don't go anywhere afterwards. Oh yeah, lunch is 20 minutes, so the timer is on. So take your time, eat, enjoy, talk, and then we'll come back and then we'll split into the different stages.
They shouldn't take their time. They've only got 20 minutes. So
Yeah,
don't
20
take your
minutes.
Time. You've got 20
Eat
minutes.
fast. Eat standing up.